Okay, very good morning, all the teachers, and a warm welcome to today's session, FDP program sponsored by AICTE and conducted in the JNT University Anantapuram and JNT Otpri Pharmacy College. A warm welcome to today's speaker, Dr. N. Koteswar Rao, working as a scientist and assistant professor, Illinois University, USA, and you are very fortunate enough to have such a eminent intellectual and speaker for delivering a talk to the faculty members on various present pharmacy education and research present and future challenges. With this, I am welcoming to the Dr. N. Koteswar Rao, and I am requesting to the Monica, faculty member, JNT Otpri, introduce the today's speaker to our faculty fraternity. Thank you very much. Monica.
Thank you, sir. Good morning, sir. Good morning, everyone. All the dignitaries and my faculty members. I'm Monica, academic assistant, JNT Otpri, and I warm welcome to online six days faculty development program. So it gives me an immense pleasure to introduce distinguished speaker, Dr. Koteswar Rao Garu. So I am honored to welcome sir. Sir has completed his B.Pharm, Nagarjuna University, and M.Pharm, Andhra University. So sir has finished his PhD in National Sciences from Acharya Nagarjuna University. And sir currently working as assistant professor in pharmacology, California Health Sciences University in USA. Koteswar Rao Garu previously worked as research assistant professor in University of Linnaeus College of Medicine, USA. And also sir was worked as associate dean and senior lecturer in Taylor's University, Malaysia. And sir started his career in lecturer in Geetham Dental College and Vizag. He has been awarded with Sudhir Gupta Young Scientist Award and Dr. Reddy's Laboratories in 2018. And Best Poster Presentation Award in 2017. And also Best Research Paper Award by College of Pharmaceutical Sciences. And sir has nearly 15 conferences presentations. Sir has presented 26 oral and poster presentations. Koteswar Rao Garu has 39 publications. Sir has guided 4 PhD scholars and he also trained 19 students. And she was member of various professional bodies like IPA and Indian Pharmaceutical Society and Association of Pharmaceutical Teacher of India and Association of Biotechnology and Pharmacy, along with American Society for Pharmacology and Experimentals and also Therapeutics. Sir is also having editorial board membership like Journal of Pharmaceutical Research and Healthcare, International Journal of Advances in Pharmaceutical Sciences, and International Journal of Pharma Sciences, and also ARC Journal of Pharmaceutical Sciences, and also Journal of Chronotherapy and Drug Delivery, and Global Trends in Pharmaceutical Science Research, and also International Journal of Pharmacy. And Koteswar Rao Garu was reviews for 26 journals. So with this information of Dr. Koteswar Rao Garu, I would like to thanks for providing me this kind of opportunity to introduce today's distinguished guest, Professor Koteswar Rao Garu. Thank you, sir. Thank you, Principal, sir. Thank you so much.
Thank you, Dr. Gopinath and Dr. Monica.
Thank you, sir.
Nice introduction. Let me share my slides first. Can you all see my slides?
Yes, yes.
Okay. So basically, I'm a stroke research scientist. I'm a pharmacologist. So we worked extensively on ischemic stroke. We tried to evaluate the novel signaling mechanisms, their role in blood-brain barrier damage, brain damage. So we want to come out with something which can able to retrieve the damaged cells, repair the lost neurons, at least prevent the ongoing damage. These are our objectives behind our stroke program. This is a part of our research, and the title of this research project is Exosomes Improve Ischemic Stroke Outcome. This work is performed in University of Illinois, College of Medicine at Peoria, and a part of analysis and data interpretation is carried when I shifted to California Health Sciences University last year. So coming to the first part, what is stroke? Why we want to bother about it? There are a lot of problems like diabetes, hypertension, cardiovascular diseases. So why you want to work on the ischemic stroke exactly? First of all, let us talk about what is stroke. So what is stroke? Stroke is sudden interruption of oxygen and glucose supply to a particular part of the brain cells. When there is sudden interruption supply of oxygen and glucose, the brain cells will be starving. They will be facing a trouble that leads to necrosis and that leads to cell death. Many mechanisms are involved in this particular process. There are two types of strokes. One is ischemic stroke, another one is hemorrhagic stroke. Ischemic stroke is mainly due to a blockade of a particular blood vessel in brain. It can be a blood clot, a blood clot just blocked a artery that is called as thromboembolic stroke. It can be due to atherosclerotic plaque, where lipid materials deposited on the walls of arteries and they narrowed down the blood flow. Ultimately, the blood flow to further regions of the brain may be blocked 80 to 90%, thereby insufficient oxygen, insufficient glucose supply will occur. If it is completely blocked, that's a big deal. So when there is an artery is blocked, there will be no blood supply to the brain cells. Next, coming to the other type of the stroke called hemorrhagic stroke, where a major blood vessel bursts. Due to the blood vessel burst, there will be a lot of leaking of blood, and the blood will be spilled out to various regions of the brain, adjacent regions of the brain exactly. Thereby, the blood on the brain suddenly stops their viability, function, everything. So brain cells starts dying. That's the problem. So either of these strokes, major problem is cell is under trouble. So neurons, brain cells, all are in trouble. When brain cells are in trouble, it is the command center for the whole body. When certain region is affected, that may lead to peripheral functions loss. For example, if there is a problem in nigrostriatal system, if this stroke occur at that cortical region or nigrostriatal region, motor functions will be affected. That's what we commonly see. So we have to bother about stroke. If anybody have these symptoms, sudden face drooping, arm weakness, speech difficulty, if they are all together in a particular person, that's the time, it's the time to reach emergency department. Here in United States, you need to call 911. There in 108, whatever emergency call number, they have to call immediately. The ambulance has to carry the patient as soon as possible to the hospital. And the patient has to get treatment as early as possible. Why? It is the second leading of leading cause of death worldwide. I thought cardiovascular diseases, I thought accidents, or I thought cancer. They are the reasons behind the deaths, but stroke is our second leading cause of death in the world. Then 1 out of 20 deaths are due to a stroke. So at least one candidate out of 20 deaths is mainly due to stroke. Most bothering point apart from these, it is the leading cause of long-term disability, especially when a patient got ischemic stroke that causes loss of motor functions, sensory functions. Sometimes memory is also affected. That's the great burden to the family, to the country, caregivers. Everybody will be under stress. It is the leading cause of long-term disability. That's the problem. So long-term disability, when it occurs, especially in terms of ischemic stroke, we can save the patient, but it leads to a lot of dysfunctions in the body, leg paralysis, hand paralysis, a part of the face will be pulled to one side, and then they can't remember, they can't see properly. So everything, they need support. If that person is the breadwinner, he is the boss, he's getting the money for the family well-being. If that happens, stroke occurs in that particular person, that stunts the whole family suddenly, and they are economically down, and viability, their day-to-day life, everything will be in trouble. Second, this person always need a caregiver. It can be a family member, it can be a nurse, it can be anybody. Every minute, the whole day, 12 hours, 24 hours a day, they need assistance. They can't do their own functions on their own. That's the problem. Third, treatment requires a lot of money. If they are insured, still country have economic burden due to this. That's the problem. So ischemic stroke, normally we can save the patient, but due to ischemic stroke, there is a great long-term disabilities in front. Whereas in hemorrhagic stroke, the patient fatality is so much. Percentage of survival is very less after ischemic stroke. So ischemic stroke, major contribution is towards death, whereas ischemic strokes contributes in long-term disability. So either of that is a real concern. We need to address, we need to find some therapy. Every 40 seconds, a stroke case is reported. Every 4 minutes, someone dies of stroke. Over 600,000, means 6 lakhs over cases are reported every year. And it was $70 billion, and they are projecting it to $180 billion by 2030, which is a huge amount. So we need to address, if we can provide a better therapy and retrieve back the lost neuronal damage or cells. By that, if you can retrieve motor functions and sensory functions, that will enable the families to survive properly. Economic burden will be reduced. By all means, we need to work on this. 87% of the strokes are ischemic strokes. That's the reason we selected ischemic stroke as our research program. So when ischemic stroke occurs, there will be especially in thromboembolic stroke model, the blood with the fibrin networks will be intact, and they will start forming a clot, and that clot blocks the whole artery. That's the problem here. When, as I explained, if a person observes those symptoms explained in my earlier slides, if they confirm that it is stroke, time is really, really important. As soon as possible, you take the patient to the hospital, the better you can save the patient. You can avoid loss of functions. If you delay the process to go to the emergency department and the treatment, there will be much more worse outcome of stroke. So the functions, there will be more loss of functions and there will be more damage in the brain cells. That's the problem. Time is really important in ischemic stroke. And when ischemic stroke occurs, the first part, some part of the brain cells will die due to lack of oxygen and the glucose, that we call it as core. The core contains dead cells, the dead neurons and dead brain cells. The adjacent region, these cells are still alive, the green colored region, which I'm talking about. These cells are still alive, but they are in trouble right now. This region is called as Penumbra Region. Penumbra Region is in trouble right now. It is in danger. So if the time is delayed, the Penumbra Region cell starts dying, and that leads to increased radius of the core. Thereby, it causes a lot of problems. So we have to immediately take the patient to the hospital and get the treatment as soon as possible. What is the treatment currently available? Tissue plasminogen activator is the class of drugs approved for treatment of ischemic stroke by FDA. What is this? It's a serine protease. What it will do normally, tissue plasminogen activator converts plasminogen into plasmin. Plasmin cleaves the fibrin mesh network. So the fibrin degradation leads to breakage of the blood clot. When the blood clot is broken due to the fibrin network is gone, that small particles, we call it as fibrin degradation products. So the whole clot is now converted into small fragments, thereby they will dissociate from that region. Then blood flow starts from this side to the other side of the brain cells. When blood flow starts, we call it as reperfusion. First, when the blood clot blocks the artery, prevents the blood flow to the other region, we name it as ischemia. Ischemia means preventing the oxygen and glucose supply. When we break the clot using the tissue plasminogen activator, then the blood flow still reperfusion starts. Blood flow again starts to the brain cells, that we name it as reperfusion. So ischemia, first phase, after treatment, reperfusion will occur. But the problem is the treatment with TPA, when onset of stroke is observed right now, within 4.5 hours of the onset of stroke, the patient must receive this treatment. If the patient receives the treatment after 4.5 hours, this drug has the tendency to cause blood vessel damage. So when blood vessel damages, it bursts and it leaks the blood. So ischemic stroke will be converted into hemorrhagic stroke. That's the problem. So treatment limitation is, one of the limitations is when stroke occurs, within 4.5 hours of the time, patient must receive TPA. If you may ask me, what about after 4.5 hours? If there is a patient from rural village, can't able to reach the city center, and then it's already 8 hours, then we have surgical procedures, thrombectomy, like procedures they'll use to remove the clot. But time delay is already there. that leads to damage to the brain cells further, and it will be more worst. That's the problem. Then why we need to work on stroke treatment? Why we need to find a novel drug, a novel therapeutic target? What is the need? The problem is TPA only cleaves the clot and facilitate reperfusion. Reperfusion means reinstating the blood flow. So blood flow will be again brought back to normal by removing the clot. That's what TPA will do. TPA will not address reperfusion after the blood flow again started. It carries a lot of inflammatory mediators because there is damaged cells. The inflammation, especially the resident microglia, gets activated and it causes a lot of damage. So secondary damage is led by inflammation. Reperfusion also causes further damage, secondary damage. TPA will not address it. That is the first problem. Second problem, TPA never repairs, never bring back the lost cells, neurons. That is the problem. Third, it can't bring back the motor and sensory functions which are lost due to ischemic stroke. So there is no functional recovery, there is no repair, there is no retrieval of brain cells and neurons, and also it can't able to control the inflammation mediated secondary brain damage. So we have to think about which can, for a drug or a combination of drugs, which can prevent the acute inflammation mediated secondary damage, which can able to bring back the lost neurons and regenerate the lost neurons and brain cells, which we need to find a drug which can improve the lost functions, motor and sensory functions, including memory, if it is affected. That's why we researchers around the world are trying to work on it. We took one of the objective is stem cell therapy. We used a human umbilical cord blood-derived stem cells. So human umbilical cord blood-derived stem cells were used for the whole study. We found that stem cell therapy, it has a lot of impact in stroke outcome in both female and male rodents. When we treated with stem cells after ischemic stroke, there was a lot of improvement in motor and sensory functions. That's what we reported in International Stroke Conference in Los Angeles, as well as we recently published in Stroke and Vascular Neurology, which is a journal in BMJ group, British Medical Journals group. So, can you note it, please? Okay, thank you. Stroke and
faculty members.
Yeah, Gopinath, go ahead.
Okay. Koteshwara, can you increase the voice, please?
Yeah,
can you speak
can
louder?
You hear me now?
Yes, yes. Okay, proceed.
So we published our
proceed.
abstract in Ischemic International Stroke Conference, and we also published our research paper in Stroke and Vascular Neurology, which is in British Medical Journals group. We found stem cell therapy is interesting, and stem cell therapy can improve the motor and sensory functions in male and female rats. So, but there is some limitations with stem cell therapy. Stem cells are macromolecules. Stem cells have their own limitations. Macromolecules, as we all know, due to the intact integrity of blood-brain barrier, they can't cross the blood-brain barrier. They can't enter into the brain. That's the problem. Then you may ask me, how could you get the effect after stem cell therapy? What's happening is after stroke, there is significant blood-brain barrier damage. Due to blood-brain barrier damage, the tight junction proteins are destructed, and that leads to enlarging the pores in blood-brain barrier, and thereby stem cells able to enter into the central nervous system. But they are macromolecules. Our stroke program aims at we want to prevent the blood-brain barrier damage. We want to regenerate the lost cells. We want to prevent the secondary inflammation-induced brain damage. So we don't want the blood-brain barrier gets damaged and thereby increase the stem cell entry into the central nervous system and get the repair process. No, that's not our idea. We are working on several things. This is a part of it. So macromolecules can pass through the blood-brain barrier unless it is damaged in ischemic stroke. And stem cell therapy also have the problems of malignancy. It can cause carcinogenesis, cancer. Immunological reactions are other problems because you are entering a foreign cell that leads to immunorejections, immunological reactions. Those are the common problems with stem cell therapy. Then we started thinking of what we can do. These are the great therapeutic entities. Is there any way we can use them and provide a therapy? Then literature says the stem cell therapy, stem cells secretes some valuable secretions called as exosomes. Exosomes are the secreted products of stem cells. When you inject stem cells in that particular region where you need therapy, depending on the situation, stem cells are producing some secreted products called as exosomes. Exosomes works as a signaling molecules, and thereby they start rejuvenating the cellular regeneration, and they are trying to repair the lost cells. Literature already had this information. The advantages of exosomes over stem cells are they are micromolecules. They don't need any carrier. They can just enter into the blood central nervous system, even though blood-brain barrier is intact. That's the first benefit. They contains, if you produce exosomes, if you instill stem cells in a stroke mimicking condition and gets the exosomes from there, and if you inject to the patient, these exosomes contains the valuable microRNAs, proteins, long non-coding RNAs, which are straight away provides a great benefit to the particular problem. In our case, it is ischemic stroke. So therapeutic benefits are more with these exosomes. They are already processed products. So when you give the processed product, it starts its work within a short period of time. That's the advantage. High compatibility, because they are not foreign cells, they are just secreted products. So immunogenic reactions will not occur. There won't be any malignancy produced by stem cells. So exosomes have a great role according to the literature. And when exosomes enter, they will start regulating the pathogenic mechanisms, and they will start inducing the repair mechanisms. Thereby, they tries to produce the new cells in the damaged area. So we want to work on exosomes. Our hypothesis is exosomes which are collected from stroke mimicking conditions. If you take some cells, you mimic stroke in vitro to that cells, means you deprive the cells with oxygen, you deprive the cells with glucose, and keep them in that condition for some time. After some time, you remove that condition, like TPA therapy, you removed blood clot and you reinstated the blood flow. That means oxygen and glucose is now getting supplied. So we took some cells and then we induced oxygen and glucose deprivation. After some time, we again supplied oxygen and glucose to those cells, which are already in some hypoxic and hypoglycemic condition. Then we tried to instill the stem cells. After TPA therapy, we normally see this kind of situation. So glucose and oxygen supply will be reinforced. Then we reinstill the stem cells. These are stroke mimicking cells, and we instill the fresh stem cells in that environment. And due to that environment, stem cells have the capability to regenerate depending on the conditions. So stem cells secreted the exosomes we want to collect, and we want to compare these exosomes with normal exosomes, hypoxic exosomes, and therapeutic efficacy. So what, in a conclusion or hypothesis, what we believe is, if you instill stem cells in a stroke mimicking environment, then stem cells will secrete more benefit containing exosomes. So exosomes having more benefit if we collect in that process. That's what our hypothesis is. So what we selected, we wanna isolate the exosomes in 3 conditions. One is just normal condition. We just culture the stem cells and then we collect the exosomes from there. Second, we wanted to instill some of the stem cells. We selected stem cells for this whole process only. So we culture the stem cells, some amount of stem cells, and then we induce hypoxia to those stem cells. And after they got hypoxia, new stem cells will be instilled on that damaged stem cells, and we collected exosomes. Then we took stem cells, we induced oxygen deprivation, glucose deprivation for some time, and then we instilled fresh stem cells on that damaged cells. So we collected exosomes in those 3 modes. First mode is normal exosomes. What we did is we took 1.5 million stem cells, and 1.5 million stem cells are plated in a 100 mm plate, the Petri plate. As you all know, cell culture lab requires huge sterility. If you violate sterility, then your experiment is gone. So sterility is major important factor in your experiments when you are working with cell culture lab. So we maintained great sterility. We never use one pipette. We use always one pipette per step. So after the step, the pipette will be removed out, new pipette will come into action. 1.5 million cells were cultured in a 100 mm plate. Like that, 6 plates containing each 1.5 million cells were cultured. When they were cultured, how they grow. We have MSC grow low serum complete medium, MSC medium. The vendor supplied it. We didn't have any, we didn't prepare it at all. Vendor supplied, and that medium we used for stem cells. Stem cells also supplied by vendor, and we always took passage 1 or passage 2 stem cells. We maintain them for 6 to 8 passages. After that, we don't use them. So these stem cells were having this media, and they are maintained at 37 degrees in an incubator containing 5% carbon dioxide. So that's how we put this Petri dish. Those who are in cell culture experiments, you all know about it. These are the stem cells. When you instill them within 6 to 8 hours, they start adhering to the plate. These are adherent cells. They're not non-adherent. They adhere to the plate. And this is how the stem cell look. And you may ask me, what is this floating cells? They are the dead cells. Immediately after 24 hours, we will wash the cells with 1x Pbs, sterile 1x Pbs, to remove the dead cells. And those cells which are adhered, they remain on the plate. and we add a fresh media to that. And every 2 days, we changed the media. And after the cells are confluent, totally full in that plate, we used to divide, and that's how we got lots of stem cells. But in this case, 1.5 million cells we instilled here. When they are properly overnight, after tomorrow we came back, we saw through the microscope, everything is settled. Then we washed the cells to remove the dead cells and added in fresh media. And after 12 hours, the culture media will be replaced with 6 ml of exosome depleted FBS containing DMEM. What is this? Normal culture media have fetal bovine serum. Fetal bovine serum have its own exosomes. I don't want those exosomes for my experiment. So I took a media which is not having FBS, fetal bovine serum, as a constituent. So fetal bovine serum free DMEM media was taken. That is 6 ml of the media is added to each plate. Here, there is no fetal bovine serum, so there is no cross exosomes. We want only stem cell secreted exosomes. We don't want fetal bovine serum having exosomes. So cross contamination was avoided. There is no FBS in the medium we used. 6 ml of DMEM was added. First, the cells are washed properly. The plate is washed. Then we added 6 ml of exosome-free DMEM media. And then 24 hours, we incubated in that FBS-free DMEM media. After 24 hours, the media is collected. Why? That media contains all the exosomes secreted by stem cells. So those exosomes we need to isolate. We centrifuged it at 200 grams for 30 minutes and removed the cells and debris, because we want only media, the media containing exosomes. We don't want the dead cells. We don't want any dead cell content or any cell content came in. So we centrifuged. The pellet is the waste, and the supernatant, the media which is stored there, we took without disturbing the pellet. We transferred into the another fresh tube. There, the clear supernatant liquid is now with us. The clear supernatant liquid have the exosomes. Then we used exosome isolation reagent supplied by Invitrogen, and 1 ml of the supernatant which we collected is added with 0.5 ml of reagent. So first estimate the volume, how much is the liquid, and based on that, for each 1 ml, we added 0.5 ml of the exosome isolation reagent. It was incubated in 2 to 8 degrees freezer, and overnight incubation was performed. After incubation is completed, we centrifuged the sample at 10,000 grams, 1 hour, which is a cold centrifuge, 2 to 8 degrees centrifuge. Centrifuge with refrigeration process. So aspirate it, the whole liquid is discarded, and the pellet is our required sample. This pellet have the exosomes. This pellet is dried, and then it is resuspended with 1x PBS depending on your requirement. Sterile 1x PBS is used to resuspend the pellet. And until we use it for further experiments, we stored it at -20 degrees centigrade. That is normal exosome storage. What about hypoxic exosomes? We took stem cells, we seeded the 1.5 million cells, as I stated in my earlier process. Same, the stem cells are seeded, 1.5 million cells per plate, 6 plates we took, and we added the same media, we maintained, incubated them for 12 hours. After 12 hours, they are adhered now. And we replaced the FBS fetal bovine serum free DME media. We washed the cells and we see that everything is gone. And then we added each plate 6 ml of exosome free DMEM media, FBS free. Then we grown it and we maintained. But what happened is after the cells are properly settled, we introduced media and we introduced hypoxia. What is hypoxia? Hypoxia means less amount of oxygen supply, more amount of carbon dioxide and nitrogen. We used a hypoxic chamber sold by Billups and Rothenberg company. This hypoxic chamber have the meter. It is connected with carbon dioxide and nitrogen cylinders. And that meter, when we place the plates and we switch on the cylinders, these cylinders consistently go in and drives out the oxygen. There will be an outlet. First, initially, the outlet will be opened. So when it reaches to 5% or below 5% oxygen, exactly 4.9 or 5, then the inlet and outlet will be clamped out. So there is, right now, inside environment is 5% oxygen or below 5%, 4.9, 4.8 around. So at that percentage, the whole system is clamped. There will be no inlet, there will be no outlet. The whole system is now packed. This incubator is placed back into the incubator, the 5% carbon dioxide and 37 degrees incubator, and we kept it for 3 hours. What is this meaning? In hypoxic chamber, there is no sufficient oxygen. So cells are not having sufficient oxygen for 3 hours. So we induced hypoxia. After that, we took out the plates, we removed the hypoxic conditions, we removed the media, everything, and then we added 0.5 million fresh stem cells, and we added exosome-free DMEM media to that cells. So first cells are hypoxic induced cells. So they got some oxygen deprivation. They are in trouble. Now you added fresh stem cells on that environment. When fresh stem cells are added, according to the situation, stem cells start secreting the exosomes. And those exosomes, which I described by earlier process, we collected it. We added the exosome isolation reagent, we incubated, and then we collected the pellet and dissolved in sterile 1X PBS. Third process is oxygen glucose deprivation. First process, we didn't do anything. We just collected exosomes. Second process, we only cut the oxygen. Third process, we are cutting both oxygen and glucose. So we are depriving the cells with oxygen and glucose absence. Stem cells, 1 million cells were plated first onto the plates, six plates, and 12 hours later, they are completely settled. And when they are settled, the media now is a special media, which doesn't have glucose. So glucose-free, FBS-free DMEM media. So glucose-free media is different. FBS-free DMEM is different. First, we use glucose-free media in this process. We added glucose-free DMEM media. Thereby, we are depriving glucose. There is no glucose right now. And we introduced hypoxia in that condition. We placed the Petri plates in the hypoxic chamber, and we also reduced the oxygen levels in the chamber as described in the above slides. So both glucose and oxygen content is less for 3 hours. They are in that environment. So it is stroke mimicking condition. Stroke is nothing but oxygen and glucose deprivation, means content of oxygen and glucose is less. Here we mimicked the same condition to stem cells. So stroke occurred now to the stem cells. After 3 hours, we replaced the media. We added the fetal bovine serum-free DMEM media with glucose. Now we don't want to deprive any more glucose. That media is added. We added another 0.5 million fresh stem cells. These fresh stem cells, because there is stroke occurred stem cells already, when they are introduced in that environment, they start secreting the exosomes to repair those stroke occurred stem cells. So we wanted to collect those exosomes. Those exosomes were collected by the above described process. So we have normal exosomes, we have hypoxic exosomes, we have stroke mimicking condition collected exosomes, which we call it as oxygen glucose deprivation exosomes. So 3 types of exosomes we have in hand. They are stored in freezer. How to confirm they are exosomes or not? They have a particular antibodies. CD9, CD81, CD63 are the antibodies which are present in the exosome pool. Already literature had defined it. We are not inventors. So we ran the immunoblots for the samples, and we found that there is presence of CD63 antibody. So then we confirmed that, yeah, these are exosomes, definitely. And we also sent for molecular size and everything, but we haven't reported it. That's why I'm not discussing them. Then we told that we deprived for oxygen and glucose in one set of the exosomal samples derivation. So oxygen and glucose is deprivation occurred or not? You are telling that you maintain free of glucose, you maintain free of oxygen. How to define it? Whether you did it properly, there may be a leak in your hypoxic chamber due to regular usage. You don't know how to define it. There is one HIF-1 alpha antibody expression. The protein expression of HIF-1 alpha is abundant in OGD conditions. Literature described it. So we ran RT-PCR with the mRNA collected from the RNA collected from the stem cells undergone OGD. We collected them, and we also collected the RNA from normal cells. We ran the RT-PCR, keeping housekeeping gene GAPDH, and we found that there is a marked increase in HIF-1 alpha in OGD induced cells. That means oxygen glucose deprivation occurred perfectly. So we concluded that here there is oxygen glucose deprivation. We successfully did this process. Apart from that, we ran the Western blots, immunoblots, confirming these exosomes are confirmation of exosomes required here. So we ran the Western blots for the 6 samples, and we found abundant CD63 antibodies present in those samples. The literature says presence of CD9, CD63, CD81 antibodies defines as exosomes. They already did their work and concluded that that's the process for confirmation. So we confirmed hypoxia here. We confirmed they are the exosomes. Definitely they are the exosomes. Then comes to the real picture. We have the therapeutic molecules. We want to induce stroke right now. We want to test them. We chose a rat model, and we chose middle cerebral artery occlusion surgery, which is a microscopic surgery. You can't see the blood vessels normally with a naked eye. We used a microscope to perform the surgery. Through the microscope, we used to see and do the whole process. How did we do that? We anesthetized the rat using isoflurane and oxygen as a combination. 2% isoflurane is used to anesthetize the rat. Throughout the surgery, the rat is alive. After the surgery also, rat is alive. We want it. We want a stroke-induced rat. That's the major requirement. Second requirement, across all the surgeries you are doing, 50 animals, 100 animals, your stroke consistency must be significant. If there is a significant difference between one group of rats to another group of rats, you can't. So we have a strict rules for inclusion of the stroke-induced rats. First, let us discuss what we did. What we did is we did middle cerebral artery occlusion using an intraluminal silicone rubber-coated monofilament suture. What we did is we first cut the neck region of the rat and we exposed the common carotid artery and we clamped it with an arterial clamp where we want to stop the blood flow. Then we also exposed the external carotid artery where one side of the external carotid artery was tightened with a tight knot. So when tight knot was performed, there is no blood flow to this region. So one way, external carotid artery blood flow is blocked. Common carotid artery blood flow is blocked. External carotid artery blood flow is blocked. Now we exposed the internal carotid artery. We put an arterial clamp also here. Between the junction of internal carotid artery and external carotid artery, we made a loose knot. This is not tightened, it's a loose knot ready for further process. In between these two knots, we made an incision and we introduced the filament, monosuture, intraluminal silicone rubber-coated monofilament suture. So this filament was introduced here. We traversed it throughout here and we removed this clamp, and then the filament is traversed through the whole brain region until it reaches to the middle cerebral artery. We pushed it slowly. 18 to 19 millimeters of the monosuture filament is required for blocking the middle cerebral artery of a 250 grams plus or minus 5 male rat. And we need the same length, but difference in monofilament suture diameter for female rat, age having a body weight of 220 plus or minus 5. But either cases, we blocked the middle cerebral artery. So through the filament, it reached here, it blocks the blood flow here. Why middle cerebral artery, you may ask me? Majority of the strokes are, ischemic strokes are mainly due to blockade of middle cerebral arteries. Then question arises, how much time you will take for the surgery? No, there is no much time. We came to an expertise, 15 minutes is the time to perform the whole surgery. From the time we open the rat neck region to complete the whole surgery, it takes 15 minutes. After the surgery is done, we tighten the knots and we conclude that the filament stays there. Then you may ask me how you can tell that the rat is always after relieving from the anesthesia, it will move. So how do you completely say that it is having 2 hours, 1 hour, whatever filament stays there, it's still blocking the blood vessel? We performed laser Doppler experiments. We have a laser Doppler with us. So we tested it. We concluded that our procedure is significantly blocking the blood vessel. So in the real scenario, this is the common carotid artery we took from microscope, and this is the internal carotid artery. This is the external carotid artery. Through the external carotid artery, as I described, the filament will traverse and block the middle cerebral artery. So that filament, after the filament is inserted, we tighten the loose knot. Now the filament won't move at all, it blocks. Then the question arises, Okay, you did a great job, definitely. Is there a brain damage? Like ischemic stroke induced brain damage? Is there a brain damage? After 1 day of what we did is we introduced the filament. We again clipped back the neck region and we waited for 1 hour, 2 hours, depending on our requirements. In this study, we waited for 2 hours. The filament is intact for 2 hours. Then we re-anesthetized the rat and we opened to the tight knot, we removed the filament. Then you may ask me why. We mimicked TPA treatment. TPA treatment cleaves the clot and again reinforce the blood flow. Reperfusion starts. So 2 hours of ischemia we induced, and after 2 hours, we again allowed the blood to flow normally, like TPA treatment. So both primary damage and secondary inflammatory mediated damage we want to address. After 2 hours of ischemia, we took out the filament and we again sutured back the neck region. We injected analgesics like buprenorphine, and we gave antibiotic treatment to avoid infections, and post-surgical care was taken properly. Our guidelines are very strict. You can't misuse the animal by any means. Then the question arises, great, you're telling my middle cerebral artery occlusion, everything is perfect. Is there a brain damage? Then we performed TTC staining. TTC is a chemical, and when it enters into the live cells of the brain, it will be converted into pharmazine. Pharmazine is a pink-colored insoluble component. So the live cells, intracellular enzyme will convert this TTC into pharmazine. When pharmazine is produced intracellularly, the cell captures the color of the pharmazine. In case of normal rat, which is not having any surgery, you can see the beautiful coloration overall in the brain hemispheres. This is contralateral, this is ipsilateral. Both hemispheres are having all together nice live cells. That's why the TTC could stain. These are 2 mm coronal sections of the brain. We stained them with TTC. When it comes to the stroke-induced rats, we introduced the filament at the ipsilateral region. We didn't introduce the filament in contralateral. That's the reason contralateral region cells are alive. When it comes to the ipsilateral region, due to 2 hours of hypoxia, there was significant damage in the brain cells. After 1 day of reperfusion, we sacrificed these rats and we tested their brains for ischemic damage. We found that significant damage is in front. We don't want severe damage. We don't want mild damage. We selected moderate damage, ischemic damage. But we can't every time kill and see dissect the brain and do the TTC staining and confirms that, yeah, ischemic stroke is there. That's not our objective. We want a live rat having ischemic stroke. So how to detect it? Normal rat can walk directly, straight line or any side, whichever way it wants. When it comes to ischemic stroke rat, because of its disability, it can't move to that side. It will be circling to its non-paratic side. So paratic side, it will lose its ability to move. It can't able to walk straight. It will be circling. Second, when you hold the tail, normal rat, 4 limbs are parallel. When it comes to the ischemic stroke induced rat, the injured side, it can't extend its forelimb. Only one forelimb it can extend. If you are bringing near to the floor, here 2 limbs will parallelly go and tries to touch the floor. But here there will be only 1 limb. The other limb can't able to extend due to paralysis. When you put it on a beam, because we will train them to walk on the beam to test this before surgery. Before surgery, every rat can walk on the beam freely. Normal rat can walk one end to another end, 1 meter beam freely. When it comes to the stroke-induced rat, due to lack of motor functions, it tries to hug the beam or it tries to fall down. So what we did, this study, we trained the rats before 3 days. Day 3 before, day 2 before, day 1 before surgery, we trained the rats for several neurological tests. One of them is beam walk. Then on the day we performed the surgery, middle cerebral artery occlusion, and we induced ischemia for 2 hours. Filament is introduced and filament retained for 2 hours. After 2 hours, we removed the filament. So we induced reperfusion here, and reperfusion times 1 day, 3 day, 5 days, 7 day, we extended depending on our requirement. And at 1 day, one group of rats, number of n is equal to 6, were euthanized, and their brains were undergone TTC staining. At 3 days, we performed euthanasia and we performed TTC staining again. So 5 days, 7 days, we performed all the neurological tests. Later I will discuss modified neurological severity score tests, sticky tape tests, beam walk tests. And at the 7th day, we euthanized and we perfused the rat and we collected the brain and we preserved it in formalin for immunofluorescence studies and further studies. But after 2 hours of ischemia, when we removed the filament, immediately at this point, we injected the exosomes. So treatment intravenously, route of administration is intravenous. After 2 hours of ischemia, we removed the filament, we sutured back the rat, and immediately through intravenous route, we administered the exosomes. Whatever exosomes we administered at this time point. And then now when we tested we collected the brains of normal exosome treated rats and hypoxic exosomes treated rat. There is no significant difference, but there is improvement in brain infarct size and swelling, but there is no significant difference observed in those samples treated rats. When it comes to the oxygen glucose deprivation collected exosomes, when we treated a group of rats with these exosomes, we could see that there is a marked reduction in brain infarct size and brain swelling. You can see there is a significant reduction compared to the illustration, the figure which I have shown in my earlier slide. Sorry. So infarct size is reduced significantly and swelling is reduced significantly. Inflammation leads to swelling. So these exosomes could combat the swelling as well. But at the 3rd day after treatment of exosomes, we could see a lot of improvement. That is our interesting point. Then we took another multiple groups of rats, n is equals to 10 here. For these experiments, we conducted several tests, modified neurological severity score test after the reperfusion point at day 1, day 3, day 5, day 7, we performed these tests. So modified neurological severity score test, it tests both motor and sensory functions. It's a battery of tests. Its score ranges from 0 to 18. 0 is normal rat, 18 is worst stroke-induced rat. 0 to 6, we call it as mild stroke, 1 to 6, mild stroke induction. 7 to 12, moderate stroke-induced rat. 13 to 18, severe stroke-induced rat. We don't want either mild or severe stroke-induced rats. To maintain severe stroke-induced rats, death is very, very significant. When it comes to mild stroke-induced rats, we could not differentiate the treatment as well as the stroke rats. So we selected moderate stroke-induced rats as our test groups. We tested the motor, sensory, reflex, and balances. One of the tests I can the rat is circling to its one direction because its limb is paralyzed. Its limb is paralyzed and it can't able to walk properly straight. So that's the problem with this rat. Due to that, it will be circling to one direction. When it comes to second test in MNSS score, we test the rat, we put it on a beam, whether it can able to freely stand or not, we test. You can see in this rat, due to lack of limb coordination, limb is paralyzed. So limb is always dropping from the beam. You can see that in this video. So that due to that, either the rat will fall down or rat will hug the beam. We will be scoring. We have multiple scores for each test, and we will be scoring for it. For example, if it falls down within 15 seconds, we are immediately, then we score it as 6. If it stays normally on the beam, we will score it as 0. When it comes to the next test, this is a sensory test where we touch the vibrissae, nothing but its mustache. So it will be touching the table. When normal rat mustache touch there, vibrissae touch there, it automatically senses there is something and it will lift its paw. But when it comes to this stroke-induced rat, even we are touching several times, only 1 in 20 times or 1 in 10 times it can lift, but 19 times it can't. So we conclude that there is loss of motor, loss of sensory, reflexes, everything, balance is gone. So when we tested, compared with untreated rats with treated rats, we could observe that there is no much significant difference in normal exosomes treated rats, but there is a little bit significant difference in exosomes with hypoxic MSCs treated rats. So hypoxic and OGD exosomes could show some improvement, but normal exosomes treated rats, there was some difference between the groups, but it's not that significant. But we can see from 0, there is a marked difference. There is a marked difference. Deficits are clearly observed from 0 to here. It is around 8 or 9, and it will be shown. It is consistently seen over 7 days. And when it comes to OGD treated rats, in this case, we could see that from day 1 itself, from untreated rat to OGD exosomes treated rat, there was a marked difference. Their ability to cope up with the test, walk on the beam, or walking in an open field, or touching the vibrissae. When we touch the vibrissae, lifting the leg and putting it on the table, everything was significantly different. We could see that exosomes could improve the motor, sensory, balance functions markedly over 7 days compared to the untreated rats. And beam walk test we used for motor coordination. What is beam walk test? Before 3 days, day 3, day 2, day 1 before surgery, we used to train the rat to walk from one end to another end. This beam is around 1 meter long. Then this rat is placed on the beam. Normal rat can walk through normally from one end to another end just like easily because we trained it. But in this case, stroke-induced rat, it has no limb capability to hold. Grip strength is lost. Motor coordination is lost. That's the reason it fall down. That is the test differentiating from ischemic stroke-induced rat with normal rat and treated rat. That's the difference. When the treated rat is there, initially it has the disabilities. On the go, due to the treatment, improvement was markedly observed. So in this case, 0 means when the capability is less, we used to score it as 0. If the rat straight away you put it on the beam, it fall down, then it is 0. If it stays, hugs the beam, it is 1. It can walk freely, then we used to give 6 as a score. So 0 is the worst here, 6 is the best. So 0, we could see that there is a great motor coordination defects, deficits in the stroke-induced rats, untreated rats. even normal exosomes could not improve it. But in OGD treated rats, you could see that there is a great difference between untreated rats and treated rats. The first day itself, they could show that there is less damage because they are controlling the secondary damage due to inflammation. Acute inflammatory damage was protected from there. That's the difference. That's the reason they were showing a great difference from day one itself. And apart from that, they started repairing the brain cells. So improvement was markedly observed with this. Adhesive removal test is also a sensory test where we put a tape on the paw and we will see that whether it can attempt to remove. We first acclimatize it and we start, when it starts attempting it, then we start the clock. We measure how many times it attempted in a period of 30 seconds. If you see this, a normal rat can able to attempt continuously 30 out of 30. It can attempt every second it attempts it. That's the normal rat. When it comes to stroke induced rat, if you see it, even though the tape was adhesive tape was there to its paw, but due to lack of sensory functions, it could not, because normal rat in this video, you could see that something is obstructing my paw, so it tries to remove it. But in stroke-induced rat, it will not attempt it due to loss of sensory functions. And we could see that sticky tape, when sticky tape, adhesive tape, it won't attempt at all, then its ratio will be very down. If the ratio is 1, then we call it as good. If the ratio is near to 0, it is bad. So we could see there is a great damage in the untreated rats. So when we treated with exosomes, we could see that the attempting number of attempts were increased compared to the normal untreated rat. So stroke is induced. We didn't give any treatment. Attempts were worst. When we treated with oxygen glucose deprivation collected exosomes, we could see that it prevented the brain damage. It even improved the brain cells retrieved back, and it improved the functions. Adhesive attempting, it is trying to attempt the removal of tape. So by all means, we concluded that exosomes, when we introduce the stem cells in stroke mimicking conditions, they secrete better exosomes and they are more better therapeutically beneficial. So exosomes could improve neurological functions in stroke-induced rats, whereas exosomes isolated from normal or hypoxic cultural conditions, they could improve, but not as good as OGD exosomes. That is our finding from this study. We recently published last year in Cellular Physiology and Biochemistry, and we also published it in 2019. Sorry, we published it in Neuromolecular Medicine. And I would like to acknowledge my friend, my mentor, and my everything behind my United States journey, and Dr. Krishna and Dr. Kloffenstein, my friends, Dr. David Wang. These are the 3 collaborators, me and Dr. Chelaboina and Dr. Krishna Kumar, Dr. Kloffenstein, Dr. David Wang, all together successfully brought 1.7 million grant from National Institute of Health. And we are working on this stroke program for various signaling pathways. And David Pinson is a pathologist, and these 2 are master students who worked with me for this particular study. And Dr. Gopinath asked me to tell my story of my life. I was born in a small village called Penganj-Prolu in Krishna district, which is near a town called Jagaibeta, where it is famous for one of the goddess, Tirupathamma. And I was grown there until 7 years of age. My grandfather was my guru. When my mother went for studies, I stayed with my grandmother and grandfather, her father and mother. And my grandfather was my first guru who taught me the basic things. And then I transferred, my mother got a teacher job and we transferred to Bhadrachalam in Khammam district, Andhra Pradesh. Now it is Telangana state. My whole schooling was there. Burgampahad is a small village where I studied, and I even don't know how to speak English properly. I was having a lot of limitations. Still, I came to Vijayawada to study my +2 residential in a residential college, and I studied my +2, and then I took mathematics, physics, chemistry as my subjects. I was supposed to go to the engineering stream. I was topper of mathematics. Surprisingly, I hate biology, but with my rank 3,637 in MSET mathematics, I could get B Pharma free seat in Siddhartha College of Pharmaceutical Sciences in Vijayawada. That's where Dr. Gopinath and myself, we are the batchmates. We studied 4 years bachelor degree, Bachelor of Pharmacy in 1994 to 98. And during our study, where I already told I don't like biology, first year was the whole biology. I have to study and pass it. It was nightmare to me. I studied, I got completed my bachelor degree. Then I progressed to Andhra University for my master's degree. Surprisingly, I opted pharmacology as my major. So M-Pharma with pharmacology as my major. I studied there in Department of Pharmaceutical Sciences. Now it is College of Pharmaceutical Sciences, Andhra University. And my great gurus from bachelor degree and master's degree, they taught me a lot of things and knowledge. Still, I can remember what experiments I have performed in my bachelor degree and my master's degree. I have a great photographic and audio memory. So kinesthetic, obviously, for everybody, what we do, we learn from there. It is common. I'm a person, when I see something, I can remember forever. So these capabilities brought me here to this level. After completing my master's degree, I decided to start working. So I worked for a little bit of time, but my first job was in Roland Institute of Pharmaceutical Sciences in Berhampur. After working for a limited period of time, I again came back to Andhra University. I want to perform my PhD. I was given an opportunity to work in a US-based company project. For 6 months, I worked in that project, and I got really great knowledge with streptozotocin-induced diabetes, where I could induce type 2 diabetes in neonates model. And then we worked a lot of compounds, evaluated their efficacy for type 2 diabetes. And after 6 months, I got an opportunity to work for my PhD, where this time I worked for formulation development and pharmacodynamics. We developed oral and parenteral formulations of glipizide for controlling the glucose levels in diabetic patients. Then during my PhD work, I got an opportunity as a founder member of Geetham Dental College, one of the founder members of Geetham Dental College in Geetham University right now. At the time, it was not university. So I established the pharmacology practical sessions, where initially they were practicing some extracts and elixirs preparation. I just washed out them, and I started introducing toothpaste, tooth powder, mouthwash, where B Pharma knowledge helped here. And I introduced all those preparations, and dental council visitors to inspect the college accreditation appreciated me at the time. And they even invited me to train their fellow pharmacologists in their colleges. That was my first innovative step in a dental college. And I concurrently worked for my PhD in 2006. I submitted my PhD. At the time, Andhra University had a vice chancellor. He didn't allow me for admissions. Not only me, he has some different ideas to control the onboarding years together living students. So he closed admissions for 4 years. Then I decided to register in Acharya Nagarjuna University, and I submitted my PhD in 2006, and my PhD was awarded with Acharya Nagarjuna University. My PhD has one of the interesting award. We published an article in Indian Journal of Pharmaceutical Sciences, and we received Best Research Paper Award, ML Khurana Award from IPC, Indian Pharmaceutical Association. One of the Indian Pharmaceutical Congress in 2004, Dr. Rajasekhar Reddy, who was Chief Minister at the time, awarded the memento to my supervisor, Professor KPR Chaudhary. So that was the first award, a national award I received for my PhD work. And then after submitting my PhD, I was evaluating my interest in international career. Then suddenly UCSI University came to Chennai at the time. So they interviewed me and they selected directly. And I entered into Malaysia, Kuala Lumpur, into UCSI University in 2007, January. After 3 years of work, 2 years, I was upgraded as senior lecturer, which is a kind of assistant professor or associate professor. I don't know which one is that. Then I was given, I really had a great time in UCSI University Department of Pharmaceutical Sciences until 2009. And this is a great city, Kuala Lumpur, with Twin Towers and Kumaraswamy Temple and many more other attractions of Malaysia. Drove me to stay 9 years there. After 3 years of my UCSI career, I was given a challenge here to establish medical school and pharmacy school as a founder member with my dean. My dean was appointed 2 months before me when I was appointed, and we both were given a big task. There is nothing right now. You established the medical school. Then we worked. I was trained for many things. I met many experienced experts in Malaysia, and I introduced integrated MBBS curriculum. Integrated curriculum means anatomists, if you take cardiovascular system, anatomists will come and teach cardiovascular anatomy. Then physiologists will come, dynamics, and then pathologists will come and teach how the disease progress, and pharmacologists will come and teach how to treat that particular conditions like heart failure, myocardial infarction, or sinus bradycardia like conditions. Then I also introduced a simulation center where we used to have simulated mannequins, sim man, sim baby, sim lady, pregnant woman. We used to simulate certain diseases through the software. It is like a human, simulated human. We used to introduce certain conditions like cardiac failure, myocardial infarction, asthma, those type of viable hypertension like conditions using software. And we used to train the students. And we used to have mock patients. We used to appoint some people as mock patients and gave the early experience. And we also have hospital visits. I introduced in that curriculum. We introduced problem-based learning, case-based scenarios. Even I was stern in my pharmacology curriculum because I developed the whole pharmacology curriculum. Initially in the year 1, there is antimicrobial therapy. So whole antibiotics, antiviral, antifungal was there. But when they start hospital rotations in year 3, I found that I even thought before they are going, when you study in the first semester of the year 1, you may not remember fully what you studied about antimicrobial agents. These are important. Antibiotics are commonly used drugs. So physician must have great knowledge. So I introduced in year 3 first semester, case-based scenario infectious disease module. I visited all the top hospitals of Malaysia, asked them which kind of diseases are prominent here. I collected all the infectious disease and introduced all those case scenarios, taught them perfectly. Then they were introduced into the clinical rotations. I worked as Associate Dean for Teaching and Learning, where I did a lot of job. I introduced all these. Apart from that, we introduced a online platform, Moodle, and we built all the medical school requirements. On that, we built world-class facilities. Tailors have, you just go with a pen drive and everything is in front of you. You can teach with just with pen drive. There is in the classroom, theater, every facility is available. Library is fantastic. So we had everything in front, and then we drove it to the success. Me and my dean worked for 6 years in Taylor's University. You call it as fortunately, unfortunately, disaster, very good, whatever it is. We came out on the same day. 2015, December 31st was my last day and his last day. He retired. I resigned because I got an opportunity in the United States to work. Before that, I was awarded, a student voted me best lecturer. That was the award introduced in 2015, first time. And there were 40 above faculty. I won the award, and all the 5-year students opted me. That was the one of the best awards in my life. And then I got opportunity to work in a stroke research program in University of Illinois. I entered into United States with J1 visa, Peoria, which is nearby Chicago. So visiting scholar, I started my career as visiting scholar, and then I was appointed as research assistant professor later. I led the whole lab. The residents, neurology residents used to come and get trained under me. I led postdoctoral scientists and masters, graduate students. I am known as troubleshooter by anybody. That my lab says I'm a troubleshooter. I don't need to see or look for any protocol procedure where it is. That was my specialty. I got many awards, and I worked for good research projects. I published in neuroscience, neuromolecular medicine, translational stroke research, stroke and vascular neurology. And recently we are writing paper for Proceedings of National Academy of Sciences. That's how we went through. We both were successful, me and my mentor, Krishna. He got $1.7 million project. And then after 3-4 years of working, I got appointment in 3 universities as an assistant professor of pharmacology. Then depending on the weather, nice place, I entered into California, Fresno, Yosemite. I'm working as assistant professor of pharmacology here from May 2020. From then, this was my first when I entered into United States, into University of Illinois. And then now I'm here as assistant professor. My life progression have only 3 basic things. I only believe in myself. I never look back. I never feel like I'm inferior. I'm down. Somebody is greater than me. Those are not my thoughts. I only believe in myself. I believe that I can do anything. That's me. Second, sincerity, hardworking nature drove me here. Third, best thing is when you learn it properly. Second, if you are in bachelor degree, bachelor of pharmacy, this is your life. Your whole unit, your 40 students, 60 students, you are all together right now. So from here, when you all go out, you will help each other. That's the best thing. So maintain social relationships properly, work hard sincerely, learn it, and identify what is your great strengths. That's what I believe in. I'm a troubleshooter. I'm great at memory. I'm great at doing things accurately. That's what my strength. So identify your strength and plan your career accordingly. Then it will drive you properly. Even I have cleared the FPGEC right now. But 2011 I cleared FPGEC. I haven't taken NAPLEX yet. So when you're working for something, you plan for it. Number of things will affect you. Many people will depress you. Many people will comment you. Those are not going to help you. Only you, when you believe in yourself, that will help finally. That will drive your success. If you plan it properly, it is going to work. Nothing is going to. So thank you very much for giving this opportunity, Dr. Gopinath. And Satya Garu, you have to mute your mic. Gopinath, thank you very much. I think I took a little bit of extra time.
Babu Gopinath Ranena. Eliminated. Gopinath. Alright, Gopinath.
Satya Garu, మీ వాయిస్ వినపడుతుంది మా అందరికి.
Okay, thank you very much, Koteshwar Rao, Dr. N. Koteshwar Rao. And no, see, after seeing your the biography, most of the students, they can aim for the highest. See, where you are born in the very remote village in Krishna district. That is in Nandigama Mandal, I think so. And where you are now.
Thank you, Gopinath. Thank you.
The only thing is have the good pay to reach the destination. There's no word to express you. They were talk of stroke research, and it is
You have any questions?
And then no words to express you. Hello.
Gopinath, we can hear you now.
Okay. And see, from that too, from the MP background, even our batch will be 13 members, I think, so MPC batch, remaining are YPC. And yeah, topic is open for discussion. My dear the co-faculty members, you have any queries? And please respond in chat box.
Sir, namaste, sir.
Yeah,
And,
namaste.
Sir,
namaste.
yes, sir. It was very nice presentation, sir. So we came to know novel systems, and your bibliography is very excellent, sir. We are inspired. And from a Bhadrachalam town, I am also from hometown, my hometown Bhadrachalam, sir.
Wow.
Thank you, sir. Sir, only one question. What could be the stable delivery system of these exosomes? Sir? So final formulation, like what you are planning for final formulation for delivery?
We are planning for nanoparticulate drug delivery right now, but we haven't entered into that. We are talking with, we wanted to test on further, we wanted to analyze the proteins, microRNAs, long non-coding RNAs, and other constituents of exosomes. We wanted to, again, from this pool, we wanted to isolate the cream of which are really responsible for this therapeutic effect. And then we wanted to proceed for formulations and testing on humans.
Okay. So
Yeah,
still you are developing?
Yes,
Yeah.
right now we tested with only stroke mimicking environment. As you saw, we used only stem cells there. We mimicked stroke for one one batch of cells, and then we introduced new stem cells and we collected exosomes. Right now, what we are doing is Dr. Klaufenstein is head of neurosurgery and Dr. David Wang is head of neurology in a big hospital. We are getting the human neurons, cortical neurons, hippocampal neurons, all those neurons. And then we wanted to mimic stroke conditions on that neurons. And then we instill the stem cells and we are collecting exosomes and we will proceed with them. First, we just tested whether we can get benefit out of it or not, because human neurons is like, there are a lot of legal processes associated with it. Now we cleared everything. They are ready to supply us. So we are going to get these human cells, stem cells are human cells, and we are going to use neurons are also human neurons. And we are expecting direct translational potential. They are all human based cells. So whatever we get it, exosomes can be used for shake afros. Exosomes can be used for any neurological disorders. That's what my next sentence is.
Okay,
these
sir.
Are not only to stroke, these are also can be for dementia. These are also can be for Parkinson's and other neurological conditions. Thank you, Umagaru. I'm happy to know that you are from Bhadrachalam as well.
Thank you, sir. Thank you so much. So I born and brought up in Bhadrachalam only, sir. Now
I was in
Hyderabad
from 1980 to 1980 to 1998. 18 years we lived there.
Oh, okay. So very much senior. Thank you, sir. Thank you.
Yeah, thank you. Any more questions?
Any questions, please? And thank you very much. If no more questions, we'll give the vote of thanks by the Monica. Monica.
Yes, sir.
And once again, thank Monica.
Yes, sir. Thank you, sir. Finally, I take privilege to give vote of thanks of today's speaker, Professor Koteshwar Rao Garu. On Sir has explained a topic on exosomes improve ischemic stroke outcomes. So thank you, sir, for your valuable section on topic which covered stroke and types of ischemic stroke and hemorrhagic strokes, and what are the stroke treatments and novel therapeutics required for stroke treatments, and then stem cell therapy. So in that one, what are the limitations like immunological problems, and then stem cell therapy can malignancies. And then SOR has also covered exosomes, hypothesis, and novel exosome synthesis, and also how to centrifuge the media and exosome isolations, hypoxia. And SOR has also explained oxygen glucose deprivations and exosome conformations and oxygen glucose conformations. And then, so what are the neurological evaluations? And SOR has also explained excellent graphical representation of normal exosomes and hypoxic and OZD exosomes. So SOR has also explained neurological evaluations of beam walk test and adhesive removal test. So thank you, sir. Such a nice and very useful session. So as faculty, we will try to assist your studies to follow whatever you have suggested. Thank you, sir. And your bibliography is excellent, sir. Thank you, sir. Thank you so much.
Thank you, Gopi. He is my classmate. Dr. Gopinath is my classmate in Bachelor of Pharmacy. We studied together. Thank you, Monica Garu, for your kind words. Whatever we did, we do for what we are doing right now with collaboration with the hospitals and all. We wanted to find a drug. So hopefully, if we can come out with a combination of drugs that can help to prevent ischemic stroke outcomes, we are happy. And thank you very much, Gopi, for giving me this opportunity to deliver a session here in Jntua University. I wish you everyone good luck. Thank you again.
Thank you very much, Dr. Koteshwar Rao. Thank you very much. May God bless you.
Thank you, Gopi.